Hi, my name is Shanna M. I'm a dermatology PA from Naples, Florida, and I have the extreme honor today to be here with two of my absolute favorite and quite iconic dermatologists in the field of acne, Dr. Julie Harper and Dr. Hilary Baldwin. And we are here today to talk a little bit about one of my favorite subjects, how to treat acne. So ladies, let's talk acne.
Excellent.
Thank you so much for being here. And I just wanted to discuss a little bit today what's new, what's exciting, what has been your, kind of most exciting new therapy that's come out within the last year, and how are your patients doing with these new therapies?
Well, I mean, we have to start with our triple combination Cabtreo, which has really been I think it's the first drug we've had in quite a while that has lived up to its hype. I think all of us had a list of people that we were going to call the moment it came out, and you mentioned that you've had people now on it for 2 to 3 months, yes. and you're as impressed as you were with the phase 3 data, right?
Blown away. Yeah.
How have you experienced it?
Same thing, and I do think this is a drug. I agree. I had a list going of people that I could not wait to give this drug to. And that wasn't just because it was a triple, it was because I had seen that phase 2 and phase 3 data, and they have reset the bar. I mean, the data that we saw, all of us saw that and we're like, wow, this is different. This is not just different mechanistically. The numbers that we're seeing here are really just better than what we have seen before. So I couldn't wait to use it.
So let's level set really quick for maybe dermatology APPs that aren't involved in the clinical trials or who do not speak for companies and really don't know what was good or what was considered good 5 years ago, 10 years ago. What were impressive numbers for IGA success or for lesion reduction counts? What did that look like a number of years ago, and how does that differ from what we saw with Cabtreo?
Now we're seeing success of 50% and reduction of inflammatory and non-inflammatory lesions in the low to high 70s, and one of the studies a reduction of inflammatory lesions of 80%. And we don't have a head-to-head, and we're comparing one drug to another, but what's the best we've ever seen? 65?
Yeah. I'm thinking about that. I think from a IGA success standpoint, some of the best numbers I remember are 37 or 38%. Yeah. Would you agree with that?
Yeah. I remember high 30s being pretty impressive.
High 30s, and we were all like, "Ooh, we're really getting it done in 12 weeks, right?" And so that has kind of been blown out of the water now. And even, and I've been a little bit on a soapbox about this for a while. I think people still have a tendency to think that the oral drugs are all better than the topicals. And yet most of our oral drugs, their clear or almost clear is around 20%, sometimes 17%, 21, 22%, and now we're talking about 50%, and this was with a topical product.
Has it changed your prescribing habs?
100%.
Do you feel like it's,
100%,
you prescribe less
yeah.
systemics?
And it would have changed them earlier if I could have gotten it earlier, but I couldn't get it until March, so.
I really didn't expect it to be this good, because we had combination, the duads are all combinations that we've had before. And I thought about it, if you added clindamycin to that, was it gonna make that big a difference? And it just didn't feel as if it was. And then they went ahead and only had 150 people in each arm. And I thought, oh, they're never gonna be able to prove statistical significance with that low a number of patients. And then they went ahead and did it.
Yeah, maybe they're smarter than we are.
Yeah.
Because I remember being in a meeting and saying, I'm not sure we even need the triple now. I don't know if we need, and it is the clindamycin that we have a tendency to pick on.
Yes.
Do we even need the clindamycin now? And boy, was I wrong. And you started coming around. The second they rolled out that phase 2 data and laid it in front of you, you're like, okay, everything is contributing something here, because again, this is different. The triple is better than any of those 3 doubles. That's what we saw in the phase 2 that Hilary's talking about. So yeah.
Do you think it has to do with the vehicle? Is that, obviously vehicle is very important, but is that what the difference is? I don't know.
I don't know
either. It's probably a little bit of everything. We heard a speaker recently who said that one of the hardest things when you think a drug is really good, when you're giving a talk on it, is not to get super excited. Our job at the podium is to, just the facts, ma'am. And we're not supposed to embellish, and we're not supposed to jump up and down with glee, and it's hard not to jump up and down with glee. My patients are very satisfied. And we even talk about irritation and tolerability, which is quite good.
I want to tag on to something you just said there, though, because I agree with you on the podium. We want to stay very, level. But the story of this drug is power and efficacy, and level setting it, because the three of us stare at acne studies all the time. We know these numbers. We know we don't have head-to-head studies right now, so we got to be careful that we don't go too far down that road. But I do think part of the wisdom that we can impart is, guys, this is different. You have a right to expect a different outcome in your patients now, because we've seen a different outcome in the phase 2 and the phase 3 studies.
And I love the fact that they did the phase 2 the way they did, to break it down into the triple combination and individual dyads of 2 ingredients. Now, they weren't the separate ingredient adapalene and benzoyl peroxide that was commercially available years ago. It wasn't the clindamycin and tret that was available years ago. But the individual ingredients were so far outperformed by the combination. And I think that's impactful as well, because I think a lot of younger providers think, okay, so the ingredients are great, let's just stack them on top of each other. But benzoyl peroxide, as we know, does not play well with others. It can often degrade tretinoin and render it ineffective. You can't just layer products that have not been studied together. So I think that's part of the magic of this triple combination, is the fact that the honeycomb mesh keeps those ingredients separate, so they are able to truly hit their target.
Yeah. And we haven't mentioned adherence, opening 3 different containers and putting on 3 products every day. I don't think so.
So true.
Yeah, I don't think I would do that.
I wouldn't.
We talk about compliance all the time, and we have a tendency to be hard on like the teenage boys, and that's probably legit. But I wouldn't do 3 things a day like that, so.
Well, stay tuned for more from JD and PPA, and let's talk about acne.